Welcome to the deep dive. So picture this. You're on your first clinical rotation, maybe feeling a bit overwhelmed.
We've all been there.
Right. And a patient comes in, they've got this kind of vague abdominal pain, and maybe surprisingly, they've lost some weight they weren't trying to lose.
Okay.
Then your senior resident pulls you aside and says, look, could be a lot of things, but always keep one silent killer in mind. What silent killer might they be hinting at? And, why is it so good at hiding?
That's the critical question.
Exactly. So today, our mission is to really get into the ways neoplasms, and that means both benign and malignant tumors can impact the body. This deep dive is really for you, our future medical pros, to help you understand this stuff, hang on to it, and recall it when you need it.
Yeah, that's a really powerful way to frame it. Because you're right, neoplasms, they're not just these static lumps.
They're active, aren't they?
Exactly. They're actively talking to the body, if you will.
Yes.
Sending out signals, changing things around them,
Yeah.
often, causing damage. So our goal today really is to give you those frameworks, the tools to sort of anticipate and recognize that conversation when it's happening, hopefully early on.
Okay.
But before we get into how they affect the host, maybe let's step back a bit. What actually makes a malignant cancer cell malignant? What are those core features that make it so aggressive, so hard to stop?
That really is the key question, isn't it? It feels like trying to understand the enemy's playbook. We hear benign and malignant all the time, and benign sounds, benign. Harmless.
Right. Sounds reassuring.
But as we'll see, even a benign tumor can cause huge problems depending on where it is. So what is it about the malignant ones? What's their secret sauce?
Well, that's the crucial difference. Benign tumors usually grow, but they tend to stay put. They respect boundaries, more or less. Malignant cells, though, they've acquired this set of, let's call them superpowers.
Superpowers. Okay, I like that.
Yeah, superpowers that let them break all the normal biological rules and just spread chaos. To make it easier to remember, maybe think of the 6 pillars of malignancy. We can use the acronym AGIE-FM.
AGIE-FM.
Got it, AGIE.
Yeah, what do they stand for?
Okay, so A is for avoid apoptosis. Cancer cells basically refuse to die. They dodge programmed cell death, which is our body's normal way of getting rid of damaged cells. It's like they've hit the override switch on self-destruct.
Sneaky. Yeah. Okay, avoid. What's G?
G is grow autonomously. They figure out how to proliferate like crazy without needing the usual go-ahead signals. Think of genes like RAS or BLyCA getting stuck in the on position. Just constant growth.
Uncontrolled growth. Right. Yeah.
Is invade and metastasize. This is really the big one for malignancy. They can push into nearby tissues and crucially spread to distant parts of the body, metastasis, through blood, lymph.
That's the spreading part that's so dangerous.
Exactly. Then E is escape tumor suppressors. Our bodies have genes like ARB that act like brakes on cell growth. Malignant cells find ways to shut these down. Essentially, they cut their own brake lines.
Wow. Okay, AGIEF.
F is feed angiogenesis. Tumors need fuel for all that growth. So they cleverly stimulate the growth of new blood vessels, that's angiogenesis, to get a dedicated supply of nutrients and oxygen.
They build their own supply lines?
Pretty much. And finally, M is multiply limitlessly. Normal cells can only divide a certain number of times. Cancer cells, they often achieve immortality. They can just keep replicating forever.
AGIEFM. Avoid, grow, invade, escape, feed, multiply. That's quite a list of abilities.
It is, and it's this combination that makes them so formidable. It all comes down to mutations and key genes, of course. And there are even more hallmarks people talk about now, like messing with metabolism or hiding from the immune system. But these 6 are foundational.
Okay, so they've got these superpowers. Where does the trouble usually start? Like, on the ground. Let's talk about the local effects, the immediate impact zone. I sometimes think of it like a really bad tenant moving into your body's neighborhood.
That's a good analogy.
Yeah.
Because they do take up space and disrupt things locally. The local effects mostly fall into 2 main buckets. First, mechanical pressure or obstruction.
Just physically getting in the way?
Precisely. And second, direct tissue destruction, erosion, or invasion.
Okay, let's take the first one, mechanical pressure.
Right, so imagine like a small rock getting stuck inside a garden hose.
Blocks the flow.
Exactly. Now, what if that rock is a tumor growing in, say, your ureter? It blocks urine flow, backs things up, maybe damages the kidney, or in a bronchus in your lung. It can block air, trap mucus, and lead to recurrent pneumonia behind the blockage.
Makes sense.
And think about the skull. It's a rigid box, right?
Yeah.
There's no room for expansion.
Yep.
So any space-occupying lesion, an SOL, even if it's technically benign tissue-wise, like a meningioma, if it grows large enough inside the skull, It increases intracranial pressure, squashes the brain.
Which can cause all sorts of problems. Headaches?
Terrible headaches, yeah. Nausea, vomiting, seizures, changes in personality, neurological deficits. It can absolutely be life-threatening just from the pressure effect.
So benign doesn't always mean safe.
Not at all. Location is key. Another classic obstruction example, pancreatic head cancer.
Oh, okay.
If a tumor grows in the head of the pancreas, it often compresses the common bile duct, the tube that carries bile from the liver and gallbladder to the intestine.
And what does that cause?
Obstructive jaundice. Bile can't flow, so bilirubin builds up in the blood. Patients turn yellow, their skin, their eyes. They get incredibly itchy, have dark tea-colored urine, and pale clay-colored stools because the bile pigments aren't reaching the gut.
That sounds quite distinctive.
It is. And sometimes on exam, you can feel an enlarged but not tender gallbladder. That's called Corvihesia's sign. It strongly suggests the blockage is below, where the cystic duct from the gallbladder joins the common bile duct, often pointing towards a pancreatic head tumor or something similar blocking the duct's end. It's a really important clinical finding.
Wow, Corvihesia's sign. Okay, that's one to remember.
Yeah.
What about the other local effect? Tissue destruction.
Right. This is where the tumor isn't just squashing things.
Yeah.
It's actively invading and destroying the surrounding tissue. That can cause pain, obviously, loss of function, and bleeding.
Bleeding seems like a big one.
It really is. If the tumor erodes into a blood vessel,
Right.
bang, you can get hemorrhage. Depending on where it is, that could mean coughing up blood hemoptysis, vomiting blood hematuinus, blood in the urine hematuria, or rectal bleeding. Sometimes that bleed is the first indication something is seriously wrong.
So even subtle bleeding needs checking out.
Absolutely. Also, if a tumor invades bone, say an osteosarcoma or a metastasis to bone, it can weaken the bone structure so much that it breaks with minimal or even no trauma. That's a pathological fracture.
Ouch.
And there's even something called vascular steel. Tumors are greedy, metabolically hyperactive. They demand a lot of blood. Sometimes they essentially steal the blood supply from the normal, healthy tissues nearby, causing those tissues to become ischemic, starved of oxygen.
Okay, so the local impact is significant. But you mentioned earlier, the really scary part is when they spread, when malignancy goes on tour.
Exactly. Metastasis. That's the ability to set up shop far from the original site. And they have a few main highways they use for this.
What are the routes?
Primarily 3. First, there's lymphatic spread. Cancer cells get into the lymphatic vessels, which are like a parallel drainage system to our veins. They travel along these vessels and often get trapped in lymph nodes first.
So that's why doctors feel for swollen glands.
Precisely. Palpable lymph nodes in the neck, the axilla, or the groin can be a sign of spread. They usually hit the local nodes first, then spread to more distant ones. Remember Virchow's node? That specific node above the left collarbone? Feeling that can sometimes be a clue to a cancer lower down in the abdomen that has spread up via the main lymphatic duct.
Virchow's node. Okay, route number 2.
Blood-borne spread, or hematogenous spread. This is when cancer cells invade blood vessels, usually veins, get swept into the circulation, and then lodge somewhere else entirely.
Where do they typically land?
Common spots are the lungs. You might see multiple round lesions on a chest X-ray, sometimes called cannonball metastases. Also the liver, the brain, and very commonly, bone.
Bone mets seem really common.
They are, particularly from certain cancers. There's a helpful mnemonic for the primaries that often go to bone. The BPRT of bone mets.
BBPRT.
Yeah. Breast, bronchus, lung cancer, prostate, renal, kidney, and thyroid. Those 5 are notorious for sending metastases to bone.
BPPRT. Breast, bronchus, prostate, renal, thyroid. Got it. And the third route?
That's transcoelomic spread. This means spreading across the surface of body cavities. The classic example is ovarian cancer spreading throughout the peritoneal cavity, the space within the abdomen. The cells can flake off the primary tumor and seed onto the surfaces of other organs like the bowel and the diaphragm.
So they're literally just floating across the space.
In a way, yes, coating the surfaces within that cavity.
Okay, so we have local invasion, destruction, obstruction, and then spread via lymph, blood, or across cavities. But the impact doesn't stop there, does it? Tumors can affect the whole body systemically.
Absolutely. And this is where things get really complex, often involving effects far removed from the tumor itself. A major one is cachexia.
Right, the wasting. We touched on this, you posed the question earlier. Why do patients with advanced cancer often lose so much weight and muscle, even if they seem to be eating okay?
And the answer is, it's not just about reduced intake, although anorexia, nausea, maybe malabsorption can play a role. Cachexia is an active metabolic syndrome. It's driven by substances released by the tumor and also by the body's inflammatory response to the tumor, things like TNF-alpha, other cytokines.
So the tumor is releasing chemicals that cause this.
Yes, they actively promote the breakdown of muscle protein and fat. It puts the body into this profound catabolic state, constantly breaking down tissues, and crucially, just giving more calories often doesn't fix it. It's a metabolic hijacking.
That's really profound. It's not just passive starvation.
Not at all. It dramatically impacts prognosis and quality of life.
What other systemic effects do we see?
Immune system compromise is a huge one. The cancer itself can suppress immune function. Bone marrow can be affected. And then, of course, treatments like chemotherapy.
A double-edged sword.
Exactly. Chemo targets rapidly dividing cells, great for hitting cancer, but it also hits healthy, rapidly dividing cells, like those in the bone marrow that make our blood cells.
Eating too cold.
Anemia, low red cells, causing fatigue, shortness of breath. Thrombocytopenia, low platelets, increasing bleeding risk. And, very dangerously, neutropenia, low neutrophils, the key white blood cells that fight bacterial infections.
So much higher risk of infection.
Much higher.
Yeah.
Plus, remember those blocked tubes we talked about earlier? Like a blocked bronchus or ureter? That stagnant area becomes a breeding ground for infection. And blocked lymphatics impair drainage. So patients are vulnerable from multiple angles. Sepsis in a cancer patient, especially a neutropenic one, can be rapidly fatal.
Infection is a major threat then. What else?
Pyrexia fever. It's common in some cancers, especially lymphomas, leukemias, maybe widely spread carcinomas. Sometimes it's the tumor itself releasing inflammatory cytokines, creating a sort of cytokine storm. Other times, it's a sign of infection, especially what we call febrile neutropenia fever in a patient with low neutrophils, which is a medical emergency.
Okay. Fever. Any blood-related effects besides the low counts from chemo?
Definitely. Anemia, as we said, is super common and can happen for many reasons even without chemochronic disease. Iron deficiency from bleeding, maybe folate deficiency, sometimes even autoimmune destruction of red cells. But interestingly, some tumors can cause the opposite. Polycythemia.
Too many red blood cells.
Yes. Sometimes it's a primary blood cancer like polycythemia rubra, but sometimes it's secondary. Certain tumors, like renal cell carcinoma or liver cancer, can produce erythropoietin, the hormone that stimulates red cell production. So they cause a secondary polycythemia.
Wow. Okay, and then you mentioned the really weird stuff, endocrine and paraneoplastic syndromes.
Ah, yes, the tumor's mimicry and mischief. This is fascinating. Sometimes a tumor arising from an endocrine gland just produces way too much of its normal hormone, like a pituitary adenoma churning out growth hormone, leading to gigantism. Or a parathyroid adenoma making excess parathyroid hormone, causing hypercalcemia, high calcium.
So that's hormone overproduction from the gland itself.
Right, but paraneoplastic syndromes are different. This is when a tumor from a non-endocrine tissue starts producing hormones or hormone-like substances it has no business making. We call this ectopic hormone production.
Ectopic, like out of place.
Exactly. A classic example is small cell lung cancer, producing ACTH, the hormone that normally tells the adrenal glands to make cortisol. Too much ACTH leads to Cushing's syndrome. Or, as mentioned, various cancers, kidney, liver, some breast cancers, can produce something called parathyroid hormone-related peptide, PTHrP.
PTHrP.
Yeah, it acts just like parathyroid hormone, PTH, causing high calcium levels, hypercalcemia, even though the parathyroid glands themselves are perfectly fine and might even be suppressed. The tumor is mimicking the hormone.
That's wild. Are there other types of paraneoplastic syndromes, not just hormone?
Oh, yes. Loads. You can get neurological syndromes,
Yes.
muscle weakness, myopathy, nerve problems, neuropathies, balance issues, cerebellar ataxia. Cutaneous ones, skin changes, like acanthus nigricans, those dark, velvety patches of skin, often in folds like the neck or armpits, strongly associated with internal malignancies, especially stomach cancer.
Acanthus nigricans. Okay.
Digital clubbing, the fingertips swelling up, is a well-known sign, particularly linked to lung cancer, but also other things. And Trousseau's sign, not the low calcium one, the other Trousseau's sign, which is migratory thrombophlebitis, meaning recurrent blood clots appearing in different superficial veins, often associated with pancreatic or gastric cancer.
So many potential systemic clues. Is
Wow.
there a way to group these?
We could try another little anchor, maybe CHEFN for some common systemic issues.
CHEM. Okay, let's hear it.
C for cachexia, H for hematological changes, anemia, polycythemia, low counts, E for endocrine and other paraneoplastic syndromes, F for fever or profound fatigue, and N for neutropenia and infection risk.
CHEFN, cachexia, hematological, endocrine paraneoplastic, fever fatigue, neutropenia infection. That's helpful.
Just a way to try and cluster some of those big systemic effects.
Right. So we've covered a huge amount. Let's just circle back for a second to that fundamental split. Benign versus malignant. We said benign isn't always harmless, but the distinction is still critical, right?
Absolutely fundamental. It dictates prognosis, treatment, everything. So to summarize the contrast, benign tumors usually well-defined edges. They don't invade locally in that destructive way. They don't spread to lymph nodes or distant sites. Systemic effects like cachexia are typically absent. But, as we stressed, they can cause major problems through mechanical pressure, like that meningioma, or hormone production, like the pituitary adenoma.
Location, location, location matters, even if it's benign.
Couldn't say it better. Now, malignant tumors, often irregular borders, they invade and destroy local tissues. They do spread via lymphatics, blood, or transcoelomically. They cause significant local and distant effects due to both mass and invasion. And those systemic symptoms, cachexia, fatigue, paraneoplastic syndromes, captured partly by Scheffin, are common and tend to worsen as the disease progresses.
Okay, so for us, as budding clinicians, spotting the potential signs early is paramount. You mentioned keeping possibilities in mind. Are there specific alarm bells we should really be listening for?
Yes, having a high index of suspicion is key. Think about these red flags. These are signs and symptoms that, while not always cancer, definitely warrant serious consideration and investigation.
Red flags. Okay, let's go through them.
R is for respiratory. Things like persistent hoarseness, a cough lasting more than, say, 3 weeks, especially if it changes, or there's blood, hemoptysis, new shortness of breath,
Oh.
or getting chest infections repeatedly. E is for excretory. Blood in the urine, hematuria. A persistent change in bowel habit, looser, more frequent, or constipation, especially in older adults. Rectal bleeding. That feeling of not emptying your bowel properly, tenesmus. D is for digestion, difficulty swallowing.
Dysphagia.
Persistent heartburn or indigestion that doesn't go away with simple remedies, unexplained nausea or vomiting. Vomiting blood, hematophasis. Persistent bloating. F is for feeling unwell systemically, that general malaise or fatigue that just doesn't lift. Unexplained weight loss, really key. Fever without a clear cause. Drenching night sweats.
Oh,
L is for lumps. Any new lump anywhere, breast, neck, armpit, axilla, groin, scrotum that persists or grows needs checking out. A is for any unexplained bleeding. We've mentioned several. Sputum, vomit, stools, urine. Also, vaginal bleeding between periods after sex, especially after menopause. Or a skin lesion that starts bleeding. G is for general or neurology. Those headaches we talked about, especially worse in the morning or waking someone at night. Visual changes. New onset seizures, changes in personality or behavior, any focal neurological deficit, weakness, numbness, coordination problems.
and S.
S is for skin changes. Yellowing of the skin, both jaundice, persistent unexplained itching all over, and any change in a mole size, shape, color, irregular border, itching, bleeding. Remember the ABCDEs for melanoma assessment.
REDFLAGS. That's a really practical list to keep in mind.
It is. The message is, with every patient you see, just have that possibility tucked away in your mind. Could these symptoms be due to a tumor? Actively think about it, ask the right questions, look for these signs. It's your early warning system.
Wow, what a deep dive indeed. We've gone from the basic superpowers of cancer cells that AGJFM through the local chaos they cause, the ways they spread via lymph, blood, and cavities, remembering BBPRT for bone mets, and the huge systemic impact, with Chef as a reminder, and finally, those critical red flags. This foundation is just so crucial for you starting out.
It really is. And the key is connecting these principles, the pathology, the physiology, to what you actually see and hear from the patient. Those symptoms, those red flags, they aren't just random problems or signals. They're clues the body is giving you. Your knowledge of anatomy, pathology, your clinical skills, that's what lets you decode them.
A fantastic summary.
And maybe one final thought to leave you with. Thinking beyond the tumor itself, how does the body's own intricate network, its immune system, its metabolism, respond to having a neoplasm on board? And how might understanding that conversation, the body's reaction, open up entirely new ways to treat or maybe even prevent cancer in the future?